You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 21st, 2018. This week I'm talking aspirin, polypharmacy, statins, obesity, and methods. The big story this week is big because it affects millions of people who will now be able to stop taking an ineffective and potentially harmful medicine. The third strike on aspirin for primary prevention of heart disease came this week in the form of the ASPRI trial, which was so big it was published in not one, but 3 papers in the New England Journal of Medicine. Recall that just a month ago at ESC, the ARRIVE study, which was moderate risk people, and the ASCEND study in diabetics found no convincing net benefit for aspirin taken for preventive reasons. And now we have the massive ASPRI trial with 19,000 older patients randomized to aspirin or placebo. The trial enrolled 70-year-old patients or older from Australia and the US, or greater than 65-year-olds if the patients were Black or Hispanic. These patients were free of chronic illnesses and free of heart or brain disease. They looked at a novel endpoint. This is the composite of death, dementia, or persistent disability. Again, 19,000 patients, and the mean age of the enrolled patients was 74 years, so pretty old patients. The trial was terminated early at 4.7 years because of futility. The composite endpoint was 21.5% versus 21.2%, and essentially identical numbers of the primary endpoint. Now, in the second New England Journal paper, looking at cardiovascular events and bleeding, the authors found no difference, 10.7 versus 11.3 in cardiac events, but they did find the rate of major bleeds was 8.6 versus 6.2 per 1,000 patient years in the placebo. So the hazard ratio for aspirin was 1.38, which was significant. And in the third paper in New England, looking at death, they found, and sit down for this, a higher rate of death in the aspirin arm, 12.7 versus 11.1 per 1,000 patient years, and that hazard ratio was 1.14. This is beautiful research that does the public good. I congratulate the work of the ARRIVE, ASCEND, and the ASPRI research teams. Now it's up to us, clinicians, to not let this be like the Lind effect. Now you remember the Lind effect? He showed that eating fruit prevented scurvy, but the translation of that evidence took years, and many people died because the medical establishment remained blind to the evidence. So that while aspirin helps prevent recurrent cardiac events after, say, PCI or stroke or MI, its use as preventive means has been tested, and now it's pretty darn clear that it does not work and may even harm patients. Now, the criticism of the ARRIVE trial, that was the moderate risk patients, was that patients weren't high enough risk. That is why they did not benefit. Well, the second trial, diabetics and ASCEND, they're high risk and they did not benefit from aspirin. And now, even in people with the most potent risk factor of them all, older age, they did not benefit from aspirin either. Again, as I said, it's pretty clear that aspirin caused harm. That is a higher death rate and higher bleeding rate. The simple message for patients should be that if you don't have heart disease, don't take aspirin to prevent it. If you're older than 70, aspirin may actually harm you. The more nuanced messages for clinician pertains to prevention. Now, it's hard to prevent people from dying with single interventions, whether they're tests or drugs. And this is because humans can die from many causes. I mean, if you like medical speak, we call it competing causes of morbidity and mortality. In the same way that a mammogram may prevent a death from breast cancer or an aspirin may prevent an MI, these are only single causes of death. Making people live longer comes from affecting many different things like clean air and water, good schools, neighborhoods, strong families, and of course, the most important factor of them all, which is good luck. Clinicians thinking that just swallowing a pill or taking a test will make patients live longer exude hubris. Next topic is polypharmacy. Now, my friend and colleague Steve Stiles, who's a medical journalist, has a knack for picking important stories. At the Heart Failure Society meeting, Steve covers a study reporting that a quarter of heart failure patients are taking at least 10 different medications. Now, here's an observational study that is worth paying attention to. The authors of this study used an NHANES database to study patients with heart failure, and they broke things down on average a hyperpolypharmacy group and a non-hyperpolypharmacy group. On average, the hyperpolypharmacy group took 12 meds, while on average, the non-hyperpolypharmacy took 5.5. Non-cardiovascular medications were a substantial contributor, 6 extra meds in the polypharmacy group and 2 extra meds in the non-polypharmacy group. So the predictors of taking too many meds were pretty predictable. More comorbid conditions, sicker patients, a lower level of education and income also predicted taking more meds. Now, my friends, this study is not yet published yet, and they didn't give us outcomes, but it's so important. Heart failure patients need our help. They need our wisdom. And it belies all tenets of medicines and common sense to give elder patients more than 12 pills per day and expect the benefits to be greater than the harm. Now, these patients don't always need super specialists. They need a clinician to help them prioritize what's important. And this is where I always have to cite Victor Montori from Mayo Clinic's work on minimally disruptive medicine, in which he argues that let's let people with heart failure take the meds that are most important to their goals of care. I mean, this week I saw a patient on 2 loop diuretics, another patient on 2 types of beta blockers, and another elder with non-ischemic heart failure on 80 milligrams of atorvastatin. And remember, we have not 1 but 2 RCTs, Corona and GC heart failure, showing no benefit for statins in heart failure. The hashtag I would propose here is make heart failure care less heartless. The third topic today is an observational trial on statins. Now, speaking of polypharmacy, an observational study from Spain took on the question of statin benefit in patients older than age 75 who have yet to have heart disease. So again, older patients' primary prevention. The study included nearly 47,000 adults with a mean age of 77, and data came from a database of the Catalan primary care system in Spain, and it looked over 10 years. And the key finding, and you know how these studies go, researchers separated statin use and non-statin use and then looked at outcomes. And they adjust for confounding covariates because the sample is not randomized. So the first key finding is that the authors separated the statin versus non-statins based on diabetes and not diabetics. So first, the non-diabetics. For these patients, for coronary events and all-cause mortality, there was no significant reduction with statin versus non-statin use in either the old group, 75 to 84, or the very old group. Now, in diabetes, there was an effect with statins. For coronary events, there was a statistically significant reduction of about 22 to 24% in older individuals and the very old. Now, diabetics between the ages of 75 to 84 who took statins also had a significant reduction in all-cause death, but not unexpectedly, statins had no effect on all-cause death in very old patients with diabetes. So it looks like a differential effect of statins in diabetics versus non-diabetics in this observational study. Now, I have to be careful, of course, because it is observational. Given that statins are the most studied drug of our lifetime, I would not even mention the study except for the fact that RCTs include very small numbers of older patients. The statin decision in the elderly, therefore, has to be made with a lot of uncertainty. So I agree with the accompanying editorialist who highlighted the need for incorporating patients' goals in this decision. The best paper on statins, I think, is the Feingold et al. Paper in BMJ Open, and I'll link it in the notes for this podcast. And it looked at the distribution of lifespan gains from primary prevention. And essentially, the authors conclude that it's wrong to think of average effects of statins, but rather that some people gain big from them while most patients gain nothing. In the elderly, the odds of gaining big is lower than for the young because the older have competing diseases to deal with. The older patient also may, and I emphasize on may here, be more likely to have adverse effects from statins. Now, one final thought, most cardiac events in the elderly are non-fatal. And while young people put huge value on avoiding death, some older patients who have lived a long life already may put more emphasis on reducing heart attack and stroke. Now, as a trusted advisor to patients, doctors, trusted advisor, I try my best to fit the best guess on treatment with each patient. Some people feel distress about stopping the statins, others welcome it. One thing I learned from our news story was that there is an ongoing RCT of statins in the elderly, and this is great news. The next topic is on obesity. So the estimates have billions, not millions, of people in the overweight range. More than 500 million people worldwide are currently obese. And any doctor treating patients outside of the third world knows this obesity is a huge and major problem. And preventing obesity and helping people lose weight is an everyday challenge for most types of clinicians, not just cardiologists. So what is the best evidence? Well, here's where we look to the evidence experts in preventive therapy, the USPSTF, the United States Preventative Services Task Force. And I like the USPSTF because they have no financial conflicts. I know, of course, any human who looks at evidence comes at it with some bias, but the USPSTF seem not to have a, quote, dog in the fight. They recently reviewed the evidence on interventions, both behavioral and pharmacotherapy, for weight loss or weight loss maintenance. Importantly, this systematic review, excluded studies of people with diabetes and established heart disease. JAMA published their findings on 4 types of interventions for weight loss. Behavior-based weight loss, they had 80 trials. Behavior-based weight loss maintenance, 9 trials. Medication-based weight loss, 32 trials. And medication-based weight loss maintenance, 3 trials. So in the behavior-based review of trials, they found not much data on outcomes, no difference in mortality or major adverse cardiac events, and not even much data on quality of life. And in 13 trials that looked at prevention of type 2 diabetes, they found a pooled risk ratio of about 0.67, which was significant, meaning that there is a signal that behavioral-based weight loss may help prevent type 2 diabetes. And in actual weight loss, the pooled results showed greater weight loss among the intervention participants, again, about 2.39 kilograms on average. The systematic review also included looks at medication-based weight loss, again, for primary prevention. The trials included multiple different weight loss drugs, and participants in the medication-based weight loss trials had more weight loss compared with placebo groups. Again, these were modest differences. The authors also looked at potential harms. While no harms were found in the behavior trials, medication trials, however, had found multiple harms, and there's too many to even list here. In the medication trials, for instance, adverse events were high in both intervention and placebo groups at 1 year, with 80 to 96% of participants experience an adverse event in the medication group compared with 63 to 94% in the placebo group. Now, the other limitations of the medical studies, and this is important, include a small number of trials for each drug. They had varying methodology, they had missing data, poor follow-up, and limited applicability. Participants met narrowly defined inclusion criteria. So those gaps in the evidence precluded the USPSTF from making an overall judgment on medication-based recommendations. They were fairly confident that behavioral-based weight loss programs do work and there's no significant harm, but for medications-based programs, the evidence was too weak. Now, look, helping people with obesity is tough, I know, but I've said this before, and I think the fundamental step clinicians must do is first notice the obesity and overweight and not make it normal. So many patients have told me that they've made changes because I, a doctor, said it was medically important. Finally, I want to mention a nifty feature we have up. Dr. F. Perry Wilson from Yale gives a brief video blog rundown on the 3 aspirin trials. The blog is called Impact Factor. How perfect is that? Now, FPW is smart, clear, and I love that he focuses on methods. Check out his final slide during his presentation. It's super important for understanding how tough it will be for new therapies to influence outcomes. So that's it for this week in cardiology. I'm grateful that you listened, And remember, if you like this podcast, please consider subscribing and giving us a review that would help other people find it. And I'll see you next week. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.